Now I will talk about neonatal resuscitation. About 10% of neonates require some respiratory assistance at birth, and less than 1% need extensive resuscitation. The Apgar score is used to describe a neonate's cardiorespiratory and neurologic condition at birth, but the score is not a tool to guide resuscitation or subsequent treatment and does not determine the prognosis of an individual patient. The Apgar score assigns 0 to 2 points for each of 5 measures of neonatal health: appearance, pulse, grimace, activity, and respiration. Score depends on physiologic maturity and birth weight, maternal perinatal therapy, and fetal cardiorespiratory and neurologic conditions. A score of 0 to 3 is low, 4 to 6 is intermediate, and 7 to 10 at 5 minutes is considered normal. A low Apgar score is a clinical finding and not a diagnosis. In neonatal resuscitation, preparation is essential. Identify perinatal risk factors, assign roles to team members, and prepare and check equipment. At least a person should be skilled in identifying neonatal problems and also in giving resuscitation. A person skilled in the initial steps of neonatal resuscitation should be available always. Before a preterm delivery, set room temperature to 23 to 25 degrees Celsius, and a thermal mattress, hat, and a plastic bag or wrap should be used for premature infants less than 32 weeks of pregnancy. There are many perinatal risk factors that increase the likelihood of a need for resuscitation, and once we identify them, we should have to have someone that's ready to give a resuscitation. Some of the risk factors include lack of perinatal care, gestational age less than 36 and more than 41, multiple pregnancy, need for forceps, vacuum, or emergency CS, meconium stent fluid, shoulder dystocia, breech, or other abnormal presentations, certain abnormal heart rate pattern in the fetus, signs of infection in the infant, maternal risk factors such as fever, untreated or inadequately treated group B strep infection. The need for resuscitation is based primarily on the baby's respiratory effort and heart rate. In addition to clinical evaluation of respiration, monitor oxygen saturation using pulse oximetry with a preductal probe. That means right upper extremity, taking into account the expected slow rise in oxygen saturation over the first 10 minutes of life. Neonatal oxygen saturation around at 1 minute of life is around 60 to 65, around 5 minutes it is 80 to 85, and around 10 minutes it is 85 to 95. Always the right upper extremity should be measured because it receives preductal blade. When we came to ventilation and oxygenation, if the neonate's respiratory effort is depressed, stimulation by flicking the soles of the feet and or rubbing the back may be effective. Suctioning, unless indicated for airway obstruction, is not an effective method of stimulation and may cause vagal response with apnea and bradycardia. For infants with heart rate of more than 100 beats per minute, who have respiratory distress, labored breathing, and or persistent cyanosis, supplemental oxygen and the CPAP is indicated. For infants with heart rate of less than 100 but above 60, who have apnea, gasping, or ineffective respiration, positive pressure ventilation using a mask is indicated. Before giving positive pressure ventilation, the airway should be cleared by gently sucking the mouth and the nose with a bulb syringe. The infant's head and the neck are supported in the neutral or sniffing position, and the mouth is slightly opened with the jaw brought forward. This is just a preparation before giving positive pressure ventilation. Airway should be cleared, and also we should have to put the infant's head and the neck in the neutral position, and the mouth is slightly opened with jaw brought forward. If the heart rate remains less than 60 beats per minute, despite 30 seconds of adequate positive pressure ventilation, chest compression should be provided. The suggested ratio is 3 chest compression synchronized to 1 inflation, with 30 inflation per minute and 90 compression per minute, using the two-thumb encircling hands technique for chest compression. If the heart rate is less than 60 beats per minute, neonates require endotracheal intubation. The effectiveness of ventilation is judged mainly by rapid improvement in the heart rate. So heart rate is the most important thing to follow for response to resuscitation. If the heart rate does not increase within 50 seconds, adjust the mask to ensure good seal. Check the position of the head, mouth, and the chin to ensure the airway is open. Sanction the mouth and airway using bulb syringe or size of 10 to 12 catheter, and also assess chest wall raise. Increase the airway pressure to ensure the chest wall raise adequately. Positive pressure ventilation should be initiated with room air for term infantis or around 21 to 30% oxygen for preterm infantis, those who are less than 35 weeks. And this is titrated as indicated by pulse oximetry. Hyperoxia or oxygen saturation more than 95 should be avoided. Infants who have otherwise responded well to resuscitation, but who are persistently cyanotic, may have cyanotic congenital heart disease. If the infant fails to respond to positive pressure ventilation delivered by mask or the heart rate is less than 60 beats per minute, the infant should undergo endotracheal intubation. Immediate endotracheal intubation is indicated if positive pressure ventilation is required for an infant with prenatally diagnosed or clinically suspected diaphragmatic hernia. In the case of clinically or prenatally diagnosed diaphragmatic hernia, positive pressure ventilation with bag and mask should be avoided. Because in this circumstance, it is not because it inflates the bowel and further compromise the lung. So positive pressure ventilation is contraindicated in the case of diaphragmatic hernia. So we should have to directly go to intubation. Regarding fluid and the medication, if the heart rate remains less than 60 beats per minute despite 60 seconds of chest compression and adequate positive pressure ventilation, epinephrine should be administered ideally via IV route. When blood loss is known or suspected based on history and examination and there is no response to epinephrine, volume expansion is indicated with 10 ml per kg of normal saline over 13 minutes. The final issue is about withholding or discontinuing resuscitation. In newly born babies with no detectable heart rate after 10 minutes of effective ventilation, resuscitation should be stopped. And in newborn babies who continue to have heart rate less than 60 and no spontaneous breathing after 20 minutes of resuscitation should be stopped after discussing with caregivers. Thank you.